The whole section is on endoscopy in pancreas. I call upon the chairpersons on the stage. Dr. Sanjay Banerjee, Senior Consultant, Kolkata. Dr. Sheshadri from Apollo, Chennai. And Dr. Kalayarasan Rajan, Professor from JIPMA.
Very good afternoon. We have assembled in the post-lunch session. And this session is on endoscopy in pancreas with emphasis on ERCP. We have two brilliant speakers. May I first request Dr. Amol Babaye from Pune. He will be speaking on disconnected pancreatic duct syndrome, optimal strategies for management. Dr. Babaye, please.
Good afternoon, and thanks to the Pancreas 2025 Organizing Committee, and particularly Dr. Sudipta, Dr. Rupjyoti, and Dr. Garg, and everybody for giving me this opportunity. Disconnected pancreatic duct syndrome, optimal management strategy is something very close to my heart. So what I'm going to be talking about is introduction, definition, diagnosis and characterization, management principles and some techniques, some special situations that we may want to take, and then some take-home points. So pancreatic duct disruption, what does it mean? So it means a defect or a loss of integrity of the main pancreatic duct causing contrast extravasation on ERCP, or without the ERCP, juice extravasation into the peripancreatic space. So types can be an opacification of the PD, which can be seen upstream, which is a lateral or a partial disruption, or it can be a complete non-opacification indicating a complete disruption. So that can be there. And that is what we mean by disconnection. So in a disconnected pancreatic duct, the area of necrotic pancreas typically is around 2 centimeters or more than that. And there has to be a presence of viable pancreatic tissue in the disconnected upstream pancreas, because if the disconnection has happened very close to the tail region, then probably this is not going to result in a disconnected pancreatic duct syndrome. That's what we need to understand. But if it occurs somewhere in the mid-body or the neck region, that's where it's going to happen more commonly. And typically it has to have a total cutoff on ERCP. And how we can suspect is that if the MPD is entering a fluid collection at around 90 degrees angle, that is where you can suspect that this can be a disconnected pancreatic duct. And why is it important? Because a delay in diagnosis of DPDS can cause increased morbidity, prolonged hospital stay, and increased treatment costs. Just a point about new onset diabetes in patients with disconnected pancreatic duct, and we can see that the risk of new onset diabetes is pretty high in these subjects as compared to the rest of the population. So when we talk about disconnected pancreatic duct, the causes typically are most common is the severe acute pancreatitis and necrotizing pancreatitis. It can occur in chronic pancreatitis in about 25% patients. And post-surgical adverse events can occur in 15% and others. Prevalence is around 10 to 39% in severe acute pancreatitis. The commonest area affected is in the neck and in the body region. And the clinical presentations, so it can be symptomatic. We can have a persistent peripancreatic fluid collection. Patients can present with recurrent acute pancreatitis, chronic pain, a persistent external fistula, or an internal fistula presenting as pancreatic ascites or a pancreatic pleural fistula. So that's how it's going to happen. But how do we suspect disconnected pancreatic duct? In a patient with a persistent fluid collection which is refractory to conservative treatment, also after a percutaneous drainage, and a refractory external pancreatic fistula after percutaneous or a surgical fluid collection drainage, internal pancreatic fistula, as I said, and these are the common presentations which require surgical management: a recurrent pseudocyst, pancreatic fistula, or a recurrent acute pancreatitis or pancreatic necrosis. So the common clinical questions when we come across this situation is, what is the choice of imaging modality and what is the optimal treatment strategy? So we have CT scan, MRCP and ERCP. And this is a systematic review which has actually compared all these modalities, and what we can see is mainly comparing ERCP and MRCP. ERCP is therapeutic and as well as the gold standard, but upstream MPD cannot be evaluated in situations where there is a complete disruption. And real-time filling can pick up minor leaks as compared to an MRCP, which where a non-dilated MPD you can miss small leaks. And of course, ERCP has risks of radiation, pancreatitis, and infection of a sterile PFC, whereas MRCP is non-invasive. So the preferred modality initially is a secretin enhanced MRCP if that is available, because that will probably improve your accuracy for identifying small leaks, or a regular MRCP if secretin is not available. And we can also perform an EUS along with the cross-sectional imaging to differentiate between a stricture and a disconnected pancreatic duct when there is no contrast leak which is evident. Coming to the management, so we have conservative approaches, percutaneous drainage, endoscopic as well as surgical drainage or resection. So in general, conservative management has very limited value. We'll come to that. And what is important to understand is use of somatostatin analogs, either octreotide or somatostatin, has shown no significant difference in patients treated with or without. So this is very important because I think this is a common clinical situation where we all encounter, and we treat very often these patients with these molecules. So conservative management basically includes watchful expectancy, and enteral nutrition is preferred always as far as possible. And that has been shown in postoperative pancreatic fistulae, although specific data for disconnected duct is lacking. And however, conservative management in presence of a documented DPDS almost never is going to work. So coming to percutaneous drainage, percutaneous drainage is not a preferred modality for fluid collection management in a DPDS because there is a high risk of external pancreatic fistulae. It can be used as a rescue therapy in the critically ill to buy time and whenever there is no expertise is not available. Sometimes a low output external pancreatic fistula may be amenable to conservative management. This is what has been shown by the PGI group, and we can it's shown that the outcomes are comparable. However, mainly when we are talking about disconnected pancreatic duct, we need a multimodality management. If there is an adjacent PFC or fluid collection, the approach should be an EUS guided cystenterostomy. If the patient has a pancreatitis or a persistent fistula or a non-adjacent PFC, when I mean non-adjacent, mean it's away from the bowel wall. So then an endoscopic approach sometimes for a transmural drainage is not available. So what is important is endoscopically we can either attempt a duct reconnection by an ERCP or an EUS guided approach or an IR guided approach, or we can attempt duct drainage by a EUS guided pancreatic gastrostomy, or occasionally ductal ablation is also been described, but more often you may also require surgical approaches which may require either cutting or an anastomotic approach, one of the two approaches. All the endoscopic approaches, because that is what I am going to be dealing about mainly, we are basically trying to create a low pressure pathway which will ultimately help in healing of the fistula. So cystenterostomy, basically a cystogastrostomy or a cystoduodenostomy is the standard procedure. What is most important for us to debate over here and to discuss is, we often leave, and there is a lot of recommendations suggesting that transluminal stents work, and whether we should leave them indwelling for a long time across the transmural tract. So this was the initial study by Bang et al., and which demonstrated that there was definite superiority of placing a transmural stent as compared to not placing one. However, in another study by the PGI group again, it showed that the difference is not that stark, but still there may be some evidence to point towards a transmural drainage. But now with this is another study by the Minneapolis group where they have shown that there is no improvement or no benefit by placing a transmural stent for a long period of time. There's another study by AIG as well where they have shown that there is no improvement by placing a transmural stent for a long term for recurrence of a pancreatic fluid collection, because the outcomes may still be very comparable. So what implications can we draw from this? Because there's a lot of confusion here. So these results do challenge the practice of keeping a plastic stent in situ indefinitely. And a logical and simplistic approach could be to treat few symptomatic recurrences as and when they do occur. However, many of these patients, it's not very easy to treat them later on once the fluid collection is drained. These are the challenges. We need to identify these patients who are likely to develop recurrence, and we need to identify how we can prevent atrophy of the tail, because it can have long-term endocrine and exocrine consequences. And the biggest challenge is to treat symptomatic disconnected pancreatic duct syndrome in the absence of a PFC. Whenever there is a PFC, the treatment is relatively simple. We can perform a transmural drainage. But once there is no collection left there and it has been drained, things really become very challenging. And therefore, this is something which we usually follow in our practice, that we do practice an early lamps removal in 2 to 3 weeks' time with an attempt to exchange to the lamps to a double pigtail stent whenever possible. And when we are unable to do that, we do inform the patient of a possible recurrence of a long-term issues related to disconnected pancreatic duct syndrome. That's how we do it. And whenever we have these approaches, how do we connect ERCP guided? So we can perform a transmural and a transpapillary approach, and we can perform this thing. Similarly, an EOS guided approach, we can perform this. We can puncture the pancreatic duct and we can get a guide wire across, and then we can place a pancreatic stent, either transpapillary by a rendezvous approach or a transmural approach. So internal drainage of the pancreatic duct, again, we can place into the disconnected pancreatic duct. We can perform this EOS guided. So this is another video which is recently performed, where you can see that the pancreatic duct is dilated, entering directly into the collection. Maybe I will just skip the video for want of time, but because I can't fast forward it. EOS guided drainage of the disconnected pancreatic duct, again, we can perform this. If there is even a small collection, that does help to target on EOS. And then if the duct is dilated, we can target that. We can get a guide wire across through a 19 gauge needle, dilate the tract, and then place plastic stents over there. Similarly, internalization of an external pancreatic fistula can be performed. So here we have a very ill-defined collection because of a pancreatic fistula, and we can place similarly a guide wire through the 19 gauge needle. And here you can see there's a guide wire coming from the external fistula, and then we are puncturing it through the EOS guided approach, and we get another wire inside, and then we can place a plastic stent over here, and that will internalize the collection, secretions, and accordingly, gradually the pancreatic fistula is expected to heal over a period of time. Ablation of the fluid production in the disconnected gland has also been described occasionally by injecting glue, cyanoacrylate glue. The main adverse event being pancreatitis of the disconnected gland, and it still needs to be evaluated in a better manner, but that is something that can be done. Here we can see that glue with lipiodol has been injected, and we can see a completely opacified but obliterated pancreatic duct. One few slides about endoscopy versus surgery, and we can see that role of endotherapy and role of surgery, the outcomes are quite comparable in this meta-analysis. What are the advantages of endotherapy versus surgery? Surgery, the pooled success rate is around 100%, 80%, but has a high post-operative morbidity and adverse events, and resection has a higher incidence of endocrine and exocrine insufficiency. Endotherapy is minimally invasive, lower risk of PEI. However, it does become challenging and requires multiple sessions. Few unanswered questions remain in the management of disconnected pancreatic duct syndrome, which I would like to highlight. Do transmural stents really provide a long-term internal drainage and prevent against a peripancreatic fluid collection, recurrence of that? Can pancreatic atrophy of the disconnected segment be prevented? And how long do we keep or change stents in case we have performed an EOS guided pancreatic duct drainage, not a fluid collection drainage? Therefore, I will leave you with a few key takeaways. DPDS is important, but it's often overlooked. There is no role of treatment for radiological disconnected pancreatic duct. We have to treat it only if it is symptomatic. ERCP or EOS guided approaches are available, and drainage in general is safer than resection. Surgical and endoscopic approaches are comparable, and we must remember that very often more than one intervention may be required. Thank you so much.